Hello dear aspirants, welcome to the session. Today we are going to discuss about the questions which were asked in the FMGE examination last year. That means PYQs of the last year FMGE examination, alright. So the first question, obviously just by looking at the x-ray, just by looking at the language of the question, you have already judged that what is the probable answer for that particular question, what is the probable diagnosis for this particular question. Now what are the three catchy points out of this question which were always or which are expected to be provided in every question related to this topic? And what are those three catch points? The catch point number one is a progressive low backache, early morning stiffness in the form of a symptom which is always provided, like progressive low backache and early morning stiffness for the last 6 months. That is point number one. Now point number two, are more severe in the morning. These symptoms are more severe in the morning and improve on the exercise. Now, this is one such point on the basis of which you have already made your diagnosis that possibly the examiner is asking about the inflammatory arthropathy of the axial skeleton, that is ankylosing spondylitis. Now, he is a known case of ulcerative colitis. That means extra-articular manifestation of ankylosing spondylitis is also provided to you in the particular question. Now, X-ray of the lumbar spine was taken and is given below. What is the most likely diagnosis the patient is suffering from? All right. So what are the three catch points in the question? One is the clinical feature. So what all you have to remember out of this particular question, always related to ankylosing spondylitis, are the clinical features. That means there will be a sacroiliac joint pain. This is not something new which you already are aware of. The first clinical feature which you should be aware of is the pain in the sacroiliac joint, all right, and the low backache with the progressive stiffness, and the symptoms are more in early morning, all right. Early morning stiffness is a sign which is suggestive of inflammatory arthropathy. That is point number one. Now, second point related to this ankylosing spondylitis that you should be aware of, that this features, all these features, they improve on exercises. So there is an improvement of the clinical features with exercises, and actually it is also a part of the major part of the treatment is the exercises, all right. So feature is the improvement with activity or with exercises, and the most important feature which will always be provided to you is the extra-articular manifestation. That means non-bony feature of ankylosing spondylitis. So the extra-articular feature which will always be provided to you, like acute anterior uveitis, the cataract, the glaucoma. These are the three ocular features. You already are aware of that acute anterior uveitis is the most common clinical feature related to the extra-articular manifestations of ankylosing spondylitis. Then there could be apical pulmonary fibrosis, then third degree heart block, then aortic valvular insufficiency, then inflammatory pathologies of the large bowel, that means colon. Apart from this, prostatitis and retroperitoneal fibrosis. So out of these extra-articular manifestation, anything could be provided to you in the form of a clinical picture, all right. So low backache, progressive, early morning stiffness with extra-articular manifestations. Answer for that question is probably the ankylosing spondylitis. Now, as far as the X-ray findings are concerned, you already are aware of that the reason for this bamboo spine actually is the calcification of the all soft tissues which are present around the vertebrae. When all the soft tissues around the vertebrae are getting calcified, so it will appear like a vertebrae in continuity. So that will appear like a bamboo spine or a bamboo trunk. So if these are the vertebral bodies and the intervertebral discs are also calcified, so this vertebrae will appear like a trunk of a bamboo. That means the entire vertebrae is in continuity without any gap, without any interference of the intervertebral disc, which is radiolucent on the X-rays. Now, in the X-ray provided to you over here, as you can see, there is a hypercalcified, this interspinous ligament is getting hypercalcified, and it is appearing more denser compared to the normal, and this gives it an appearance of a dagger. That is the reason why it is called by the name of a dagger sign. So basically, dagger sign is actually what is dagger sign? Dagger sign is the calcification of interspinous ligament, which in continuity will appear like it gives a shape of a dagger, appearance of a dagger, all right. So X-ray findings. So coupled with the clinical findings, you are having the X-ray finding, and the answer for that question goes straight away in the favor of ankylosing spondylitis. So very, very important, potentially important question, more likely to be asked in your examination every time you sit in it. All right. So expect this question, ankylosing spondylitis, in any of your examination. Next is Now, a patient who presents with a swelling and tenderness in the anatomical snuff box. Now, many of the times we have already talked about, orthopedic reference of anatomical snuff box is related with two conditions. Although it could be presented with multiple other conditions, but what are the things that you should be having in your mind when you see the term anatomical snuff box? So, every time you see the word anatomical snuff box, point number one is the scaphoid fracture that you should think about. That possibly the question might get continued in the favor of a scaphoid fracture, because in case of a scaphoid fracture, the tenderness is elicited in this anatomical snuff box. All right. Now, point number two is the dequervantinosynovitis, or the other condition with which it is related is the dequervantinosynovitis. Although it is not exactly over the anatomical snuff box, but yes, tenderness is related and is expected, or it is elicited just at the radial styloid. All right. So this is another condition like the question could be continued with. And the third one is CHERALGIA, chiralgia paresthetica. What is chiralgia paresthetica? Basically, it is the wrist watch neuropathy. All right, also known by the name of Wartenberg entrapment neuropathy. It is also known by the name of Wartenberg entrapment neuropathy or wrist watch neuropathy. Now, what happens in this? There is a compression of a superficial radial nerve. So, whenever you see the word anatomical snuff box, and anatomical snuff box is related with the orthopedic significance with these three conditions. Now, let's see which way the question goes. All right. Now, after sustaining a fall on its outstretched hand, now the moment you get the mechanism of injury for this type of anatomical snuff box tenderness, that means the question of dequervantinosynovitis is ruled out, because that is the compression of the abductor pollicis longus and extensor pollicis brevis, which is non-traumatic. The second thing, that is chiralgia paresthetica. It could be related to trauma, but it has to be associated with certain degree of numbness. All right. The image given below shows the cast which is used in the management of the patient's injury. Now, once they have decided to put it inside the cast, that means there has been a fracture, and the fracture which is related to the wrist joint eliciting the anatomical snuff box tenderness, the diagnosis is almost certain, and the diagnosis for that particular question is scaphoid fracture. So, what we are talking about, what we are dealing with in this particular question is the scaphoid fracture. Now, all of you are aware of the fact that a scaphoid fracture, the management, the treatment for undisplaced fracture, that means if the fracture fragments are not displaced, it has to be immobilized only. For undisplaced fracture, it has to be immobilized in glass holding cast. All right, it has to be immobilized in glass holding cast, also known by the name of scaphoid cast. Now, why is it known by the name of glass holding cast? Because the shape of the upper limb, all right, the attitude of the upper limb, it appears as if you are about to hold the glass, all right. So, glass holding cast. Now, how will you identify this glass holding cast? Because the thumb is fixed in, all right, the thumb is encased in abduction, while the wrist is encased in dorsiflexion. So, what are the two components of this glass holding cast? That the thumb is immobilized in, in glass holding cast, the thumb is immobilized in abduction, while the wrist is immobilized in dorsiflexion, also known by the name of extension. Dorsiflexion or extension, one and the same thing. And this is how you will identify the scaphoid cast. On the other hand, the management of a displaced fracture, if the fracture is displaced, then it has to be reduced and fixed. That means open reduction, internal fixation with a Herbert screw, which is required. But at this point of time, for this examination and for the undergraduates, you have to understand, you should be knowing about what is the management of the scaphoid fracture for undisplaced fracture. So, in general, they are asking about that scaphoid was fractured. What should be the management? The management is a glass holding cast application. How will you identify a glass holding cast? This is what we have already talked about, that the thumb has to be kept in abduction and the wrist has to be kept in dorsiflexion. Second point is, it is a below elbow cast, all right. That means elbow is not immobilized in this glass holding cast. So, that's all for this particular question. What you came to know out of this question, point number one, the anatomical snuff box tenderness, what should be the differential diagnosis? Point number two, how to identify the cast related to the scaphoid fractures, all right. Next question is, a young patient who presented to the emergency department with the pain and swelling of the right knee, all right. The pain So first of all, what they have provided to you, presented to the emergency department, obviously after the trauma, with the pain and the swelling of the right knee. Plain radiograph shows the following finding. Now, first of all, you have to identify that what is being provided in the X-ray. Now, this is the X-ray of the knee joint lateral view, because the distal end of the femur, proximal end of the tibia, the proximal end of the fibula and the patella, all of them are visualized. That means it is the lateral view. Now, what is the best treatment for the condition which is provided to you? Now, in this case, as it is very clearly evident, like there is a fracture of the patella. All right. So there is a displaced fracture of the patella, and all of you are aware of the fact that if there is a displaced fracture of the patella, which doesn't seem to be comminuted, it seems to be a transversely displaced fracture of the patella. So the management is by tension band wiring. The management has to be done by tension band wiring. All right. Now, what do you mean by this word tension band wiring, and how is it being done? The tension band wiring, how is it being done? Just try to understand. Imagine if this is the distal end of the femur, this is the proximal end of the tibia, and here we are having the patellar bone fracture. So it is fractured like this. Okay. Displaced fracture, having a displacement of more than 1 centimeter, definitely has to be managed. But if the patient is not able to extend the knee joint, so it means that there is a split in the quadriceps tendon also, as well as there is an associated retinacular fracture or retinacular injury also. So in order to have that thing, this entire mechanism, the entire biomechanics of the knee joint to be gained normalcy or to be functional again, you have to perform this fixation by tension band wiring principle. Now, here what we are about to understand, that what is the principle of tension band wiring. First of all, if we write down the word, that what is the principle of this tension band wiring, it is to convert the distraction into compressive forces. All right. You know, the action of tension band wiring is to achieve compression at the fracture site. But the principle of tension band wiring is to achieve or is to convert the tensility into compressive forces or distraction into compressive forces. Now, all of you understand that this is the weight bearing axis. The weight bearing axis is passing right through this, the femur and the tibia, and it is the posterior border of the patella which is nearer to the weight bearing axis. So anything which is nearer to the weight bearing axis would be compressive. That means the posterior cortex of the patella is compressive. So what it will result in? The anterior cortex of the patella automatically will become distractive. So inherently or normally or naturally, the posterior cortex of the patella is compressive, while the anterior cortex of the patella is distractive. Now, if there is a fracture over here, and if you try to put the two K wires anteriorly, after putting the 2K wire or after passing the 2K wires anteriorly, then you perform the figure of 8. First of all, how these patella fractures are treated. Imagine this is the transverse fracture of the patella. The two tension band wires are, or the 2K wires are inserted distal to the proximal through the fracture side, through the proximal and the distal pole of the patella. And then after achieving the reduction, it is tensioned by or it is bound by the SS wire in a figure of 8 pattern. All right, so that you can achieve compression at the fracture site and eventually the compression is achieved. Now, what I'm trying to explain it is in the lateral view. Now, in the lateral view, there are two possibilities. One is you put the K wire nearer to the anterior cortex. Second possibility is you put the K wire nearer to the posterior cortex. So, if you try to put the K wires nearer to the anterior cortex, then what will be achieved? You know, when the compression is achieved, once you have reduced the fracture and compression is achieved, so you are adding more compression or you are adding compression to the distractive cortex. The distractive cortex is getting compressed and the posterior cortex is inherently, as I told you, is naturally compressive. So there will be a compression achieved right from the anterior up to the posterior cortex. So throughout, that means from the anterior up to the posterior part, the compression is achieved. But if you decide to put the 2K wires nearer to the posterior aspect, nearer to the posterior end of the patella, so what you are doing is that you are adding more compression to the compressive cortex, as a result of which there will be more distraction to the anterior cortex and the implant will be a failure. This kind of a surgery would be proven as a failure. So out of the two possibilities, that means placing the K wires nearer to the anterior or placing the K wires nearer to the posterior, which one is obviously better, is the placement of the K wire nearer to the anterior cortex. All right. Now, by doing this, you are converting a distractive forces into compressive forces, and this is exactly what the principle of a tension band wiring is to convert the tensile or distractive forces into compressive forces, so that the entire cortex is now compressive and it will unite. It will result in near normal biomechanics of the knee joint is achieved. So hopefully everything is clear related to the principle, although highly unlikely that they will go to an extent of asking about the principle of the tension band wiring. But yes, because this question has been asked multiple of the times, like what is the management of a transverse fracture of the patella which is displaced, it has to be managed by tension band wiring, and you should be aware of that where exactly to put the K wires through. The like should be anterior, nearer to the anterior cortex or nearer to the posterior cortex. All right. So answer for this question is the tension band wiring with the K wires. You know, majority of the times or previously what they used to think that patelectomy was also the option. But you know, today patelectomy is never performed, never ever performed. You know, try to save the patella as much as possible because it has got its contribution in maintenance of the normal biomechanics of the knee joint. All right. So patelectomy is never ever performed today. What you have to do is tension band wiring. Simple. Hopefully everything is clear. Out of this question, what you should be knowing about, point number 1, that how the transversely displaced fracture of the patella are treated by tension band wiring. Second is, what is the principle of tension band wiring? It is to convert the distractive into compressive forces. These are the two points to be taken out of this question. Next question is certainly related to a tumor. The 30-year-old, first of all, every tumor related question, age has got its importance. So a 30-year-old male presented with a complaint of a gradually progressive swelling around the wrist for the last 3 months. Given below is the image of the swelling and the X-ray film. What is the most likely diagnosis the patient could be suffering from? All right. So swelling, yes, for any kind of a tumor, it could be benign, it could be malignant. There has to be a swelling, there has to be a bony outgrowth. Now, once you look at the tumor, once you identify the lytic lesion, this lytic lesion is present or is encroaching almost up to the level of joint. That means it is said to be epiphyseal lesion. Once you have diagnosed it to be an epiphyseal lesion, you are left with two differential diagnoses. Simple. For any epiphyseal tumor, this is the protocol that you have to follow, that once you have diagnosed it to be an epiphyseal lesion, you are left with two differentials. One differential is GCT, that is giant cell tumor, and the other differential is chondroblastoma. And how to differentiate in between the two? Like if you go with the X-ray appearances, for GCT, it is appearing like a soap bubble, while for chondroblastoma, it could be irregularly calcified kind of a lytic lesion in the bone. Now, for both these two findings, based on the theoretical appearance, you would never achieve the outcome, you will never achieve the diagnosis. But GCT is the tumor which appears after 20 years of age. That means more than 20 years of age. While chondroblastoma is a tumor which appears in less than 20 years of age. That means it is the tumor of a second decade of life, while GCT is the tumor of skeletally mature individual. So, what you have to additionally look for in this particular question is the age. So, age which is provided is 30-year-old, that is more than 20 years of age. Second, the confirmation of this thing has to be done by looking at the X-rays. Is there any growth plate visualized? No. All the growth plates around the wrist joint, that means distal radial, distal fibular, distal ulnar and radial growth plates are obliterated. They are no more visualized. That means we are looking at the X-ray of a skeletally mature individual. So answer for this question goes in the favor of a giant cell tumor. So what are the two catch points out of this particular question? One is the age. Age is having a significance in every kind of a tumor related question. And the second one is the X-ray appearance. So X-ray appearance for this particular question is that if there is a lytic lesion encroaching all the way up to the epiphysis, you are left with two differentials. One is GCT, other one is chondroblastoma. If the growth plate is visible, it is chondroblastoma. If the growth plate is not visible, it is GCT probably. So answer for this question is osteoclastoma, because GCT is also known by the name of osteoclastoma lesions. All right. So these are the two catch points out of this particular question. Hopefully everything is clear related to this one. All right. Yes. pediatric orthopedics, as I told you that one day they are going to ask you anything related to the pediatric orthopedics, and why not to start with the condition which is very, very frequently observed in day-to-day basis. It is considered to be the most common congenital abnormality of the lower limb in orthopedics, and that is CTEV, that is congenital talipes equinovarus. Now, what is to be looked out of this particular question? It is congenital talipes equinovarus, so CTEV. So how have you identified this CTEV? As I told you that there are at least 3 things that you need to remember related to the CTEV as far as we are running in the preliminary kind of the questions in this particular topic. All right. The first point is always the deformities, that how will you mark the diagnosis or how will you make the diagnosis based on the deformities which are visualized on this given image. So what all are the deformities in the CTEV? As far as deformities of the CTEV are concerned, it is equinus, that is fixed plantar flexion. There is forefoot adduction. The forefoot is adducted. There will be inversion of the foot. All right. Instead of eversion or into the normal, there will be a inversion of the foot. There will be equinus of the foot. There will be forefoot adduction. There will be cavus. That means there will be a deep medial skin crease instead of a plantar arch. And finally, there will be internal rotation of the tibia. Internal rotation of tibia. Now, out of these deformities, which you already are aware of as the principal deformities of the CTEV, which one is visualized in this particular image? 1. The equinus is clearly evident. 2nd, the forefoot adduction is clearly evident. All right. And the foot is said to be in inversion. All right. So, inversion, equinus and forefoot adduction, when it is seen, it is certain that possibly you are looking at the image of a CTEV. So, first thing always are the deformities related to CTEV. All right. The second thing is the management protocol, that how will you manage this condition? You know, as far as the management of this condition, the treatment of this condition is concerned, the CTEV, the treatment. So, from the newborn up to the age of, up to the age of at least 3 years of age, because previously it was considered like for 1 year of age, you have to go for posterior medial soft tissue release. For 2 years of age, you have to go for posterior medial soft tissue release. But let's start with the newborn, that what should be the management in case of a newborn. Now, what is the problem? Identification of the problem is that you are having a child with a deformed foot. And how will you manage it? By gradually correcting all the deformities so that it is overcorrected into equinus is converted into calcaneus, the forefoot adduction is converted into abduction, inversion is converted into eversion, the plantar arch is regained, and over a period of time, because the cast that you will apply in order to maintain the correction that you have achieved by manipulation is the above knee cast. So, internal rotation of the tibia is also corrected gradually over a period of time. So, serial application of the cast after manipulating all the deformities is the management protocol. That means conservative method is the management protocol for the management in case of a newborn. That is newborn. Now, so what is the management for this? It is Ponseti method. That is cast application, corrective cast application, where all the deformities are corrected simultaneously. And once the overcorrection is achieved, it has to be immobilized. It has to be kept inside the Dennis Brown splint in order to prevent the recurrence. All right. This is all about the management protocol. Now, the question is that here the age is not newborn. The age which is provided over here is 6 months of age. So, would you go with the management in the form of a surgery, or would you go with the management in the form of a conservative method? Because when you apply a conservative method in the management, then there is too much resistance in correcting all the deformities. So, which one would you go for or go with? So, previously, the posterior medial soft tissue release was done in the age groups of 1 to 3 years. But today, the conservative method is taking over the operative methods up to 3 years of age. That means, if a child comes to you with the neglected CTEV at 1 year of age, then instead of going for posterior medial soft tissue release immediately, go for Ponseti. If a child with 1.5 years of age comes to you, then go for Ponseti method. That means conservative cast application. If there is a failure, if there is a recurrence, if there is a negligence, then you can go ahead with the soft tissue release. But before that, you have to go with the conservative method. And this is the, over a period of time, this trend is getting changed from the management, that means surgical management is getting now converted into a conservative management earlier in the age groups. So up to 3 years of age, you have to first of all try for conservative method. After 3 years of age, you can go with the surgical method. That is the essence of the question asked. So if you read the question again, the 6 months old child is brought to the OPD with the deformity as shown in the image. Which of the following is your line of the management? So first of all, you will go with the conservative method. After that, if there is a failure, if there is a recurrence, if there is a negligence on the part of the parent, then you can go ahead with the surgical method. So it is a manipulation and cast. Because this is just a revision class for the FMGE examination, we have very informatively discussed the management protocol for the CTEV, how the Ponseti method is different from Kite's method, what are the advantages of Ponseti over Kite, and why Ponseti is considered to be the management of protocol today or the management of choice today. Then how the management changes for the different age groups, like what is the management up to 3 years of age, what is the management from 3 to 5 years of age, 5 to 8 years of age, beyond 8 years of age, beyond 10 years of age. So we have discussed it in huge details. We have discussed about the splints also, that what is the role of a splint, how to apply the splint, when, till what duration you have to apply that splint, and after the completion of the 1 year of age, then what is the importance of the CTEV shoe, which is provided on which the patient will start walking. All right. So everything is discussed in huge detail as far as management for this particular condition is concerned. So for your question, at least at this point of time, because these are the questions which are getting repeatedly asked. One is the identification of the problem. Second is the management of the problem for CTEV, that is congenital talipes equinovarus. So if you look at the other options like posteromedial soft tissue release, as I told you, 1 to 3 years of age, PMSTR was performed today, but today we are converting this thing into a conservative method, which is having a far better outcome compared to the soft tissue release. Triple arthrodesis is the fusion of the 3 joints in the ankle, in the talar bones, or the 3 talar bone fusion after performing the appropriate osteotomies, which has to be done beyond 10 years of age in order to correct all the deformities. All right. Dilben-Evan procedure is a procedure where you have to go for the lateral closing wedge osteotomy, and that is also appropriate in the age group of 5 to 8 years of age. So hopefully you get the answer for this particular question. Everything is discussed in huge detail during the lectures. We have talked about it. So this is the answer for this question, that is manipulation and cast. Even if the age provided to you is 6 months, 1 year, 1.5 years, likewise, if these are the ages provided to you, you have to go with the casts. All right.